Conf.gov/kids has the educational tools and information to make the conversation easy. When the time comes, chances are they'll feel prepared, not scared. So talk with your family today.
Commissioner Jan Malcolm, Director Joe Kelly, Commissioner Steve Grove, and Deputy Commissioner Heather Mueller. After our speakers, we'll get to Q&A and ask that reporters limit themselves to one question each. With that, Governor Tim Walz.
Good afternoon, Minnesota, and good afternoon to our media who are here. Once again, thank you for getting out factual information and for continuing to make sure you're here to ask the questions. Much like yesterday, I want to keep our briefing relatively short and leave the bulk of the time for questions. Unfortunately, again today, we have 2 more deaths, bringing our total to 629 positive tests. Commissioner Malcolm will go into greater detail, and I think as she and all of us reminded, those are the ones that are tested. We know that the numbers are much broader than that. Encourage people to continue on the social distancing. I know that this is running into another very good trait of Minnesotans. We consistently rank as one of the healthiest states because people do a lot of outdoor activities, but we're seeing crowds that are a little too big, especially around the lakes. And I would encourage people to continue to think about this and continue to know this is one of the biggest differences we can make. I'd also note appeals, and that is, of course, following the same process through the Judicial Selection Committee and then on to me. I'd just like to update you on just a couple of things that we're doing today, dealing with executive orders. I signed Executive Order 2025 this morning, authorizing peace officers, firefighters, and security-related licensing modifications. What this really means is the way the system is set up, we have several thousand firefighters, police officers, and security personnel that their licenses will be expiring on June 30th, 2020. And then through the normal process, they would re-up and get those done. We're just extending that time period till January 1st, 2021, so that they can focus on their frontline job. They can focus on what needs to be done, not a burden for them. So just so you know, there's no shortcuts being taken in this. These are already licensed folks who are out there doing the work they need to do. Well, the second executive order today was 2026, ensuring continuing operations in the medical cannabis program. This is an essential service for folks, therapeutic and palliative care for folks. We want to make sure that we make this as easy as possible for them. So what this does is just extends the recertification date for current patients that were set to expire over the next few months. They usually have to come back in, recertify, and go forward. This will just simply extend that out. Allows folks to request an emergency temporary caregiver to help them with medication and dispersal, and allows medical cannabis manufacturers to implement curbside delivery and telephone pharmacist consult. I'll let Minnesotans know we have the strict protocols in place for this, but this just eases the ability to get this to the folks who need it. So just a couple of those executive orders. As I said, business as usual. You'll hear from the details of the implementation plan that is the main focus of what we're doing now. So I'll turn that over to Commissioner Malcolm at this time.
Thank you, Governor. Good afternoon, everyone. As the governor indicated, we have unfortunately 2 more deaths to report in Minnesota today. I will give you just a brief global update first before going into more of the Minnesota detail, and then I think we'll begin to kind of add into this briefing just a couple of key messages for the day that we are hoping that Minnesotans will, and our provider community also will be able to pay some closer attention to. So globally, the total as of this morning was more than 801,400 cases and 38,700 deaths around the globe. The United States is now reporting 164,610 confirmed cases, making us by a pretty considerable margin the country with the largest number of cases in the world. 67,000, almost 400 in the state of New York, an additional over 16,000 in New Jersey. The U.S. is reporting 3,170 deaths, 914 in New York City alone. So we watch with sadness and concern that growing difficult situation in New York City. Again, back to Minnesota, the total of 629 laboratory confirmed cases represents an increase of 53 from yesterday. I will point out that was on a moderate volume of testing. Mondays generally are a little bit lower volume of testing as clinics are not open and couriers not delivering samples until Monday. And this is yesterday's totals that we're reporting. So we'll be seeing, we assume, an uptick in testing volume again from today forward. With the 2 additional COVID-related deaths, we now have a total of 12. Age range from 4 months to 104 years for the total positive cases. Median age of 46 years. Since the start of the outbreak, we've had 112 COVID-19 patients hospitalized, and the rest have been recovering at home. There are currently 56 patients in the hospital as of today. That is unchanged from yesterday, with an additional 2 people admitted into the ICU. So there are 26 folks in ICU today and 30 in medical surgical beds. And so 2 were discharged yesterday. So no net change in the hospitalization, but some additions, some releases. And as of today, 288 patients have recovered from the illness and have been released from their period of isolation until symptoms are cleared. And as the governor has already mentioned, we'd just like to keep repeating that the total of the laboratory confirmed cases we know is just the tip of the iceberg, and that there are more cases in Minnesota, and we should all be assuming that the virus is circulating in our communities. I mentioned that testing kind of goes up and down during the days of the week, and also as a function of laboratory supplies, which you have become quite familiar with. While there do continue to be challenges associated with specific reagents, we have been in a fairly stable situation with the ability of laboratories to move from one testing platform to another to try to maximize the available supply. And we are current with all of the samples that have been submitted to the MDH Public Health Lab. So we are not experiencing a backlog at this point in time. I'd just like to reinforce a couple of things. The governor already mentioned that the importance of keeping up our efforts to stay at home and to really minimize public contacts, to avoid large gatherings, avoid gatherings really at all with anyone outside of your immediate household. With the holidays coming up in early April, at the same time, we're seeing the expected increase in COVID-19 cases in our state. We really, really want to reinforce that this is a time for Minnesotans to keep up their vigilance. This includes having only telephonic or virtual visits with loved ones who are in nursing homes or assisted living, which is so very essential to help us protect those vulnerable Minnesotans, as well as to help us to limit the spread of the outbreak in our communities. As you might recall, we've talked often about kind of having a prioritized testing schedule for several groups, including those who are in the hospital and those living in congregate care settings such as nursing homes. However, lately we've been getting hearing some concern that some emergency rooms and hospitals might be defining this more narrowly than the guidance was intended and are restricting the definition of congregate living settings to nursing home residents only. So we really want emergency rooms and hospitals to know that they do need to make sure that other congregate living settings, such as homeless shelters and domestic violence shelters, really need to be included in that definition so that people living in those settings get prioritized for testing, similar to the way we are prioritizing nursing home residents. We also really want to make sure that workers in any of these congregate settings also are getting prioritized for testing, even if they would not otherwise be considered high priority due to their age or health status. With that, I will turn it over to Director Joe Kelly from the State Emergency Operations Center. Thank you.
Thank you, Commissioner Malcolm. Good afternoon, everyone. Today, I'd like to talk a little more about alternate care sites as we continue to go through the process of identifying facilities around the state that we could potentially use as temporary hospitals for non-critical patients. And so far, our planning team has conducted assessments of 7 facilities and validated 5 of those as potential alternate care sites. Those 5 sites could accommodate up to a little over 600 beds. The team's doing an evaluation up in the Duluth area today. And again, our goal is to identify space for 2,750 beds. That's 1,000 in the metro and 250 in each of 7 regions around the state. And again, remember, the spaces we're identifying are on top of the additional capacity that the hospitals are currently generating on site. To be clear, we are not going to immediately build out all these identified spaces and put stuff in them. We will convert facilities for this use where and when we need to. After we've selected facilities around the state that we could potentially need, we'll finalize the conversion plans. And by that, I mean create schematic drawings, build materials lists, calculate work time estimates and budget sheets. And we'll work with the Corps of Engineers, we'll get their help to line up contractors to do the work if and when we're ready to go. Our goal and what we will have in place is the ability to have a facility remodeled, if you will, and operational within 48 to 72 hours of deciding to move forward. At the same time, we'll develop a catalog of furnishings, equipment, and supplies we'll need to make the facility a functioning care site and figure out the sources of those materials. I hope that we never need any of the alternate care sites we're working on, much less all of them at the same time. And we hope the additional in-house capacity Minnesota's hospitals are generating right now will be adequate for what lies ahead. But as Governor Walz reminds us, hope is not a plan. And we need to finish the planning for the alternate care sites now and be ready to immediately execute those plans if they're needed when the peak demand for skilled healthcare approaches. So we're doing everything we can to use the time that the social distancing strategies that Minnesotans are complying with or the time that they're buying us. And as we do this important work, we need you to give your time, a donation, or some blood. Thank you. I'll turn it over to Commissioner Steve Grove of the Department of Employment and Economic Development now. Commissioner?
Thanks, Director Kelly. Hello, everybody. Wanted to start off with some new data that we're getting and then tracking now just on layoffs to give folks a sense of the layoff rate in the state. Since February 15th, we've been notified by 8 different companies of layoffs or 50 or more people. And that's something that companies in the state and the country are required to do to their economic development departments. Those layoffs since February 15th have affected about 4,011 individuals. The good news, as it were, is that they're not all permanent layoffs. Many of them are temporary or they're leave of absence layoffs, but that number is higher than the same period last year, as you would expect. Last year, during that same window of time, we had 4 layoffs of that size that affected about 1,857 individuals. So we're going to continue to track those larger scale layoffs. The big industries we're seeing those happen in are not surprising. They're retail, dining, accommodations, manufacturing, and healthcare. And we'll continue to update the public on that once a week as we get these notices in. And again, many of them are temporary, which is good. But want to provide that data to people to see how things are unfolding. On the unemployment insurance front, we are up to 255,371 unemployment insurance applications since March 16th of this year. Yesterday, we had about 16,116 applications, which compared to last Monday was down 25%. So that's a good trend. We'll continue to track that closely. We also want to continue to update the public on the demographic breakdown of those applications just to get a sense for who is affected most at this time. And we'll do that once a week. We got that data compiled again last night. And if you may remember last week, we announced that more women than men were being affected by some of the closures. And I think the numbers were 33% men and 66% women. This week it has tilted slightly more towards 50-50. We're at 54% of applications since March 16th have been women, 46% have been male. So I think this is in part due to a higher level of applications from some male-dominated industries like manufacturing and construction that have begun to trend upward in our numbers. From age perspective, workers over 30 have increased compared to last week. So overall, our unemployment insurance applicant pool is slightly older this week than last week. And the education breakdown amongst the pool of applicants is as follows. 38% of our applicants last week have a high school diploma or less. 41% have some college or an associate's degree, and 21% have 4 years of college or more. Wanted to just put in a quick plug for our shared work program. We've seen a lot of increased usage of this program. It's part of unemployment insurance. It allows businesses to reduce hours amongst a broad cross-section of workers and then use unemployment insurance to make up the gap for them, rather than just laying off a certain number of workers to make ends meet. We have seen the number of plans go up by almost double every week as this crisis has unfolded, and we just continue to encourage employers to look into shared work as a way to try to keep as many of your employees attached to your business as you can during this crisis, and let the state help cover some of the gap in the meantime. Lastly, just wanted to continue to recognize Minnesota companies that are doing great things. We were excited yesterday to see Medtronic, the storied medical and biotechnology firm from Minnesota, release the design spec and code for its portable ventilator, the PB560 ventilator, so that anybody can use those specs to build their own ventilators. This is particularly useful for inventors or startups or academic institutions, and just an extraordinary thing to see companies sharing what would usually be proprietary information with the public to increase the speed at which we can battle this disease. So I'm grateful for that news from Medtronic. With that, I'm going to turn over to our Deputy Commissioner of the Department of Education, Heather Mueller. Heather.
Thank you, Commissioner Grove. Good afternoon, everyone. We are on day 2 of distance learning, and we seem to be off to a very good start. We have a lot of pictures that are being generated and put on social media of students sitting down and doing their work and partnering with their parents and with their teachers. And so we continue to be very grateful that our educators have put in the time and that we were given the time to be able to do this work and be very thoughtful in our approach. We ask that we continue to have patience as we build that triad around our students. Again, knowing that the location is different, but the learning is the same. And the way the approach may also look a little bit different, but again, the work that we're doing and the learning that they're doing is not all that different than what they're doing in a school building. And so if you have questions, please reach out to your teacher. That is what they are used to having you do. And we ask you continue to go down that path, either their teacher or the administrator in your building. And we are more than happy to support you in that work. As we previously reported, MDE had sought a waiver from the U.S. Department of Education to waive the accountability and federally mandated statewide standardized test requirements. And we received that waiver today. So we are officially canceling the MCA test for the remainder of the 2019-2020 school year. Again, we are really thankful of the work that our school districts and charter schools are doing, as not only with the learning of their students, but also with the providing of meals, as well as student age and school age care. And so we're proud to report that during that 8-day planning period between March 18th and March 27th, districts and charters in Minnesota served over 1.2 million meals on average and had an average of 3,276 students per day receiving school age care. And so again, it only reinforces the notion that as a community, when we come together and we focus on the student at the center, there's nothing that our families, our schools, and their educators and our community cannot do. And with that, I'd like to hand it back to our governor.
Thank you, commissioners. And I'd like to just say that as you're hearing these updates, we had a regularly scheduled call this morning with the federal delegation who are on with us. I want to thank each and every one of them for the work they're doing in their communities. Also thank them for the CARES Act. And as we start thinking about what the fourth stimulus should look like, we're able to communicate with them of things that will help Minnesota. So with that, I think I'm going to turn it back over and open it up for questions from the press.
Thank you. As a reminder, to ask a question, you need to press *1 on your telephone. To withdraw your question, please press the # key. Please stand by while we compile the Q&A roster.
Our first question comes from Esme Murphy of WCCO-TV. Your line is open.
Governor and Commissioners, thank you for taking this call. I'd like to ask you, has the modeling that you have done shown you the date that the COVID-19 epidemic will peak in Minnesota? Yes or no? What are those dates? And what is your analysis of how many deaths and cases Minnesota will have by those dates?
Yeah, and I'm going to let Commissioner Malcolm go into greater detail on this, Esme. First and foremost, the modeling that's done is always just that. There are going to be variables that we couldn't count on. I think what we're seeing is the modeling that's been done on other continents, that's been done in cities here, that what we're seeing is a trend, and that trend shows a slow buildup and then a rapid ramp up if mitigation is not taken. We're starting to get some better numbers on the ability of this thing to transmit from one to another. We're seeing changes, though, in how it's impacting certain populations, and it may have to do with underlying health assumptions. And so what I want to be careful of is nothing that we're putting out is carved in stone. It gives us a good trend. I'm going to let Jan speak to the data. When I showed the data a week ago, of course, that's being continuously updated, of showing that we could push back by several weeks, and this had a margin of error in it by several weeks, but we could push this thing back into potentially into May. Late May is what we were shooting for. We're building a lot of assumptions, as you hear Joe Kelly talk about, being ready at a moment's notice if this starts to shift. So I want to remind Minnesotans that the good news about this is, I think, the tone that you saw change at the federal level was Dr. Birx and Dr. Fauci laid out these scenarios in front of the president. He acknowledged the seriousness of this and gave up his belief that we could open up in mid-April. And so with that, Jan, if you want to speak any more about that, we're certainly not dodging being specific about it, but I think it sets up false expectations of an accuracy over the trend that we're really looking at. So, Jan?
Thanks, Governor. Yes, the governor is quite correct. And just for clarity, we have not rerun the model since the governor first introduced the stay-at-home order and his thinking behind it in order to buy time. So there is not a new projection. We are, the folks at the university and our folks at the health department are refining the model, making some additional enhancements to the assumptions going into the model based on more recent data and based on trying to model more closely what we've actually done in Minnesota. So there's not an updated projection I can give you yet. That will, I would imagine, be coming in another couple of weeks. We're just starting to get enough Minnesota data to be helpful. I think I've said before, what we really like about this model is that it is specific to the population of Minnesota, the demographics of Minnesota, and what from the health department we know about underlying health conditions, chronic conditions specific to Minnesota. So while we originally were using some of the international and national data on things like infection rates and latency times and so forth, we were able to do it on the specifics of the Minnesota population. So we're going to be continuing to evolve that. As the governor said, the confidence levels, if you will, or the bands around the estimates were plus or minus a couple of weeks on either side for when that peak might be hit. So that range took us from the middle of May to the middle of June for what we would be expecting with peak hospitalizations. Hitting the capacity of the intensive care units was modeled out to be a couple of weeks earlier than that. So early May to early June, but that was with the assumption that the ICU capacity we had at the time was the ICU capacity we were always going to have. And that, of course, is one of the very key parts of the strategy to buy time to build up this capacity. I'm mentioning all that just to say there's a lot that's since the original model. So that's why we prefer to just talk in terms of the ranges and to just reinforce that we don't have an updated projection as of this time to give you.
All right, I just would like to ask a follow-up, though, because I think Minnesotans do deserve some specific dates if you folks have them. I understand there's a range, but are you saying, Commissioner Malcolm, that and Governor Walz, that the peak is in late May, but that it could be 2 weeks earlier to 2 weeks later into June?
Esme, that was the original model, yes. And when we are able to run it again with updated factors in it, that may change. We are right now just starting to be able to compare the rate of growth in our cases to what we've seen in other communities. So it's possible that that peak may have moved out further in time. But what we were modeling a week ago was peak of infections being in early May to early June, peak hospitalizations being middle of May to middle of June. So that was our planning time frame at the outset.
And Esme, I would follow up on that to let you know, if I'm going to err, I'm going to err on sooner rather than later. So the sense of urgency you feel from us, the sense that you heard from Joe Kelly is that I'm asking him to have those places ready to go now. I'm viewing this as if there is a misprojection, we need to make sure that we don't believe we have more time than we actually do. I think it's prudent. We can't tell people it's not going to happen next week. I think we can speak with fairly strong confidence on that. But we don't want people to be misled that this is still ever evolving. It depends a lot on what we do. And so far, we're doing that right on the mitigation side. But I can tell you that our planning and what I told my team is sometime here within the next 4 weeks, we need to be prepared for that to be upon us. So we'll continue to model, continue to update.
Thank you, sir.
Thank you. Our next question comes from Matt Beckett of Minnesota Public Radio. Your line is open.
Hi there. I have a clarification and then to my question. First, is the low end of the age range of cases 5 months old or 4 months old? I'm hearing, we're seeing on the website 5 months. Commissioner Malcolm, you said 4 months. My question relates to long-term care facilities. Given the concern about spread in those facilities, will they have the capacity for new COVID-19 patients who may need extended care after a hospital stay?
Yeah, Jan, I'll let you take both of those.
Sure. I think as far as I know, and I know Chris Ayersman is on the phone as a resource as well. So Chris, feel free to jump in if you have a correction, but I believe 4 months is the youngest child that we've had test positive. Is that correct, Chris?
Yes, and the child is doing well.
Thank you very much. And your question about the long-term care capacity is very important. And one of the things we really need to look at and work on with the hospitals and the skilled nursing facilities and assisted livings is the best possible protocol for caring for people and when they need to be transferred to the hospital and how we can keep them in their assisted living or long-term care setting as safely and to avoid a hospital transfer if that's possible, because that is just a kind of a recipe for more transmission back and forth. So we're working hard at those transitions of care guidelines, and certainly we are working very closely with all of the congregate care facilities and congregate living facilities, as we've talked about, to try to just make sure that the infection control processes that they have and the isolation of anyone who's tested positive, the restriction of further movement within the facility is also very important to just try to contain the spread. We know these are environments, particularly before some of the stronger mitigation efforts were put into place. They're just environments where it's just kind of ripe for disease transmission. And most of what we think we've seen has been the case of infections coming into the facility from outside, from healthcare workers who don't know that they've been exposed, or from family members before the visitation restrictions were put into place. And Chris, I'd welcome your additional comments if you have any.
So I think you covered it well. I mean, one of the things that we want to, and we're working with
congregate care facilities on is just helping them expand their capacity to care for patients. And as we've talked about before, they each have a nurse case manager that's working with them. We're working with the State Emergency Operations Center to get them personal protective equipment. So our focus at this point really is on these congregate care settings because they do represent both a vulnerable population and a population that could easily overwhelm the healthcare system. So we're working very closely with those partners.
Okay, thank you.
Thank you. Our next question comes from Tim Nelson of Minnesota Public Radio. Your line is open.
Governor, we've seen in previous epidemics that the Native community is struck very hard, and I'm wondering if you can address what steps you're making to help the tribes in Minnesota. You know, are they going to have easy access or nearby access to these alternative care facilities? Are they getting tested equitably? How are you reaching out to them?
Yeah, thank you, Jim, for the question. And you're absolutely right. It's so many things that, as I've often said, that unfortunately, when bad social situations happen or disasters, that our Native communities are the most fragile. We have close communications, and we were early on. I want to thank their leadership for taking very difficult and drastic action to close down. And in many cases, it was their gaming operations, which was their biggest source of income. And they did that very early to protect their people. We've been working very closely, as I said, with the congressional delegation. I'd like to give a special thank you to Senator Smith and Congresswoman McCollum, both of whom have been working with Indian Affairs to make sure the federal response was there. And then also one of the things that I think is very unique, and again, the legislature did this in a bipartisan manner. We were able to set up and quickly have grants to be able to move to each of the communities $1 million each for them to use on COVID response, COVID testing. At this point in time, and I don't want to speak out of order, I believe we have one confirmed case in White Earth, and we're monitoring closely. But you're absolutely right. Close communication. These are independent, sovereign nations. They have their own healthcare system that is part of what the United States government is responsible for providing, but the state is stepping up and trying to communicate with them. And the leadership by our tribal leaders, as I said again, has been decisive and exceptional, but the pressure is going to mount. So we hope that some of these unprecedented state movement of funds and the communication with the tribes will help us reduce that number. But all of the issues that we worry about everywhere are prevalent. And for example, in Red Lake, we have about 800 homeless folk, and that's an area we're all concerned about in congregate camps and things that may push the spread. So we are working it. We're aware of it. At this point in time, there is nothing that indicates that it has gotten beyond the stage where most of the rest of the state is at, but we will pay close attention.
Thank you.
Thank you. Our next question comes from Kent Erdl of KRTV. Your line is open.
Yeah, Governor, thanks. When you were talking about the modeling that was used at the time that you put in the stay-at-home order, and one of those date ranges involved ICU capacity, at the time there was talk about 263, I think, available beds. Where are we at with that? Is that a number that's been changing daily? Do we have a good estimate right now where we're at as a state, and are hospitals able to add capacity at this point?
Perfect question, Jan. I'll turn that over to you, but this is at the heart of a lot of what we're doing.
Yes, that's absolutely correct. That there's a lot of work going on with the hospitals, being very specific about how much capacity they have to convert some of their medical surgical beds into ICU beds, and we've got good projections on the number of beds that they think they'll be able to convert. Really the rate limiting factor, as we I think have mentioned on prior calls, is the availability of ventilators to be able to equip those rooms with. we're gonna have a sharp focus, and we do now on. You heard from Commissioner Robert Davis yesterday on the procurement process to make sure that we're getting the equipment to help equip those expanded ICU beds as well. But we are definitely on track to expand the number of ICU beds, and that 253 or so number, I think it's up to 260 something right now. That will change literally daily as the flu cases continue to be discharged from the hospital, freeing up more of that capacity, which unfortunately will become filled by COVID patients. But the expansion work that Joe Kelly talked about, we're just getting quantification from each region of the state about where they are with the conversions that have already been identified and how much they think they'll be able to surge to. So should have some more specific numbers that we'll be able to share with you just within the next couple of days.
Is there a target?
Go ahead, Tim. I'm sorry.
Is there a target at this point for increased capacity in either a percentage or kind of a number that you'd like to get to in the short term?
Jan, yes, there is, and this is where Joe Kelly might come in on that. We're looking at where those numbers are at. We're talking about pushing that curve out. And again, Joe made note of this, that we're standing up 250, I believe, available rooms in each of the 7 greater Minnesota healthcare districts, and then about 1,250 in the metro. And I think our goal with ventilators is to get us up somewhere near the 2,000 or a little bit above that. And those things start to put us in a place where we would be able to absorb, so we don't end up like New York. And I might mention one of the values here is Minnesota, and I'm talking to the federal delegation, setting up and planning for this came about after 9/11, and few states took it as seriously as Minnesota did. So the two and three administrations before me all took this seriously in terms of planning. And so when I'm listening again to New York's briefing, they're talking about one of the first times all of their medical folks have come together and talked was during this current crisis. We've done that before. So, Jan, I don't know if you want to clarify or if Joe does, but that's where we're headed right now.
Yeah, and if Joe happens to be looking at that bed report, I'll defer to him on this. But I think your estimate, Governor, of the number of combination of beds and ICUs that we're targeting to add is about 2,000.
Yeah, go ahead. Yeah, this is Joe Kelly here, and I don't have the numbers of the in-house hospital capacity either for the critical care or more regular care. The planning team, the doctors on that team are communicating with the hospitals on a daily basis. I don't have those numbers, but I'll see if I can get them for future calls. If I could just ask one more thing on the other end of the spectrum, when you were talking about those models early on, there was no doubt left that the longest wait would be for those families and loved ones that are in long-term care facilities and they need to keep that distance. Can you kind of explain what you're looking at long-term, if there's any kind of a ballpark for those families, and how long people should expect that they might be isolated from their elderly loved ones, perhaps?
Yeah, and this is the toughest question, as you're hearing, and I think there's not a total consensus around people, but I think people are now, and the president included, have realized it's going to be longer rather than shorter. I think there is a school of thought, and certainly Dr. Osterholm has conveyed this, that it will be many months. We're trying to figure out what is the best way to make this sustainable. So I think for those families that it's an unknown, I certainly think it'll be longer. Again, I would reiterate, we're planning, but there's some hopefulness in the research on the edge on the antibody tests and some of those, that we can start getting folks tested for some at least short-term immunity, potentially long-term, get them back out. I think that is a much more difficult question around the long-term care facilities. So I don't really see a horizon on that over the next certainly weeks and few months, but it's evolving quickly. And as new information comes in, we're certainly adapting it to what we're doing with our planning.
Thank you. Our next question comes from Mary Lahammer of PBS. Your line is open.
Thank you. This is for Governor Walz again about the long-term care facilities. I've been speaking with several business leaders in the industry, and they have a real concern about their employees continuing to come to work. As you know, these are low-paid workers, rates regulated by the government, and they're wondering if there's any incentive package to either, compel or incent these crucial workers to continue to come to work.
Well, it's a great question, and there should be. I have spoken for many years and advocated this last legislative session that these folks are not paid what they need. That goes to the personal care assistants that are not in long-term care facilities, but are going into homes, to helping people that simply could not survive the day without their personal care attendant there. And I think that brings up a valid question. We're, again, at the state trying to look at all we can, but our capacity to be able to make a difference in that area is relatively limited because we don't have the ability to deficit spend, and we're going to need the federal government to help us. So yes, these are conversations we're having. These are folks, just to be clear, there's a sense of selfless service that goes into this and servant leadership that they go to do it anyway. But if you're asking these folks, and many are making barely minimum wage or a little bit above, that's a pretty big ask. So the right now, no, there's nothing in the pipeline to be done. Are the conversations happening? Absolutely. Certainly with our federal partners to help us make that possible. But it's a great point and it's a valid one. And I hope people keep that in mind about their neighbors who are doing that, or the folks who are cleaning the hospitals the same way.
If I could follow up, Governor, is there any chance that there could just be a financial incentive package? I had one executive say, could there be just a bonus for showing up? Would you be open to anything like that at the state level instead of waiting for the federal government? Since so many of the cases, are there, and especially the fatalities right now. And, I think there's a lot of workers who are afraid.
Yeah, certainly. And I talked about this with our personal care assistants, but just so you get a grasp on the magnitude of this, if I'm able to, which I would like to try and get, certainly up to $15 an hour for our personal care assistants, that cost was around $300 million. The issue still comes back to that Minnesota cannot run a budget deficit. And because of that they're going to be constrained to whether we want to or not. I am certainly open to trying to do something. I certainly would encourage the legislature to think about it, but there's simply going to be the reality of that really only the might of the federal government and their ability to move dollars to support the state. And in this last CARES Act, it was certainly good, but I expressed, as many governors have to their federal delegation, there was not as much to the states as maybe there could have been. And that's going to have to be a balancing act. So yes, I'm certainly open to it, but this is a pretty big proposition, and we're going to need federal partners to help make it happen.
Thank you.
Thank you. Our next question comes from Kevin Beverly of Minnesota Lawyers. Your line is open.
Governor, hi. I'm wondering if you've gotten the request from your corrections ombudsman, who's requesting that legislators pass a law that would allow the corrections commissioner to release prisoners once they're in 6 months of their supervised release date. Is that something you would support? And he also recommends that if legislation doesn't pass, which is questionable because 4 caucus leaders would have to sign off on it, that you exert executive power over that. Do you support that legislation, and would you consider exerting executive authority in that case?
Yes, I certainly would consider it. I would much rather go through the legislative process. I would like us to be thoughtful about how this works, understanding that just releasing someone, that we have to make sure that they've got a safe place to live, they've got all those things, in addition to making sure that we're not putting the public at risk. But yes, I do think the concerns around correctional facilities and the inability to move folks out of there could put everyone at risk. So yes, I will tell you this, that where we have the capacity, a shorter time than that, we have been moving people. And just so the listeners out there understand what we're talking about, we had an individual who was down to her final 30 days and was ready to give birth. It made no sense to keep her in there longer, to put either her or child at risk. And so those are some of the things to move them out where the mother went into labor. I've not heard the follow up on it, but I'm assuming that it's certainly a much safer situation. So we're certainly open to it. I have brought this up to the legislative leaders. In fact, I brought it up to the Republican caucus directly because they, I think, rightfully expressing some concerns. I would like them to be engaged in this, but speed is of the essence now. And if there is the ability to move nonviolent offenders or folks who are detained, certainly folks, and I would encourage in county jail, if it's just simply a bail situation, it's not a violent crime, we should really think about trying to move folks during this time. There'll be time afterwards to get that right, but we can strike the balance between the public safety and the personal and desire to not make sure we're creating a time bomb situation we all know that our antiquated and overcrowded prison system is just a hotbed for some of this to happen. So yes, we're open to it. We're talking. We received the letter. The ombudsman's doing exactly what the position was meant to do, and we take that very seriously.
On a related matter, if you don't mind, your authority on the order that you issued giving Jody Harstead the power to keep her operations afloat, essentially, was challenged on the Senate floor, but the language that would have legislatively sort of put the stamp of approval on that did not pass. Is that a concern to you? Do you hope that that will pass, or do you think that because the Attorney General signed off on that with the Executive Council that you're covered?
Well, I do believe we are, and I think there'll be time afterwards. And I would encourage people to continue to challenge all of these if they don't think they're right. And I certainly would honor what the courts say. The fact of the matter is, I needed to act because people's lives were literally at risk in that case for the services being provided by DHS. I did encourage them to put the language in. They weren't able to do it. I will continue to try and work with them. But as I told the legislative leaders, if these situations are time sensitive and need to be made in the best interest of the safety and security of Minnesotans, I have to make them. So I do wish they would go back. We certainly believe that we are within our rights and orders. And again, these powers, as the Attorney General often reminds people, these were democratically agreed on, voted on, and passed that are given to me under peacetime executive authority. So we feel strongly that it's there. Still encourage the legislature to work on it.
Thank you.
Thank you. Our next question comes from Bill Warner of Minnesota Newsnet. Your line is open.
Governor, on a related topic, as far as the economic effects of COVID, the president's order on tail. Of that.
There's no evidence to prove that at all. It was an unnecessary move. It's one that certainly is not supported by the American public. Minnesota still has the right under the Clean Air Act to move forward on both spurring our economy, which he knows it'll be. So of all the things we have to do, probably not that necessary. The president was working on that. But there's no evidence to support what he's saying. And in fact, just the opposite. And the auto industry itself is not even in agreement on that. So we'll just keep moving forward. My focus is on COVID, and the rulemaking we have done around to move Minnesota towards a cleaner energy economy will continue on.
Do you think that the state is justified then in adopting more strict regulations as a result of this, Governor?
Yeah, the interesting thing is our regulations were the ones that were all agreed upon earlier. And I keep reminding folks they weren't above and beyond. And even though there's a narrative to try and make it like these are outside the mainstream, this is what the vast majority of Americans want us to do. It's what the economists show will make a difference. And so in the midst of all of this, to roll us back away from every other industrialized nation and probably have the biggest impact on setting us backwards on climate change just doesn't make any sense to me. So Minnesota knew that on these types of things, that if the federal government won't lead, we will, and we're going to continue.
Thank you, Governor.
Thank you. Our next question comes from Theo Keith of Fox 9. Your line is open.
Hi, Governor. A couple of quick ones. Are you going to do the executive order that firefighters want on the workplace illness designation for coronavirus? And then the other one is Paul Gazelka wants you to take the hotline down for people to report violations of the stay-home order. Do we need a hotline? Is it being used?
It is being used, and we simply want people to be able to call and let folks know, and it's for their own good. We have numbers. If somebody sees a fire at a neighbor's house, they want to tell them. If we see people that may not be as informed on this, it's an educational piece. So we're certainly going to do that. And I asked the legislature again, and I guess if you're in contact with the folks in the Senate, they didn't move on this. They seem to have a different interpretation. No one I talked to, especially the firefighters and first responders, they want this done. So yes, I'm seriously considering moving on that. I'll give the legislature a time to try and see if they can get that fixed. But our folks, our first responders deserve that too. So we'll continue to fight for that. I'd like to have them get that done, but we're not going to take down a telephone number that allows people just to try and keep their neighbors safe.
Thanks, Governor.
Thank you. Our next question comes from Jeremy Olson of Star Tribune. Your line is open.
Yeah, hi. I just had some nuts and bolts numbers questions that weren't referenced initially. One is a number of outbreaks in long-term care facilities, along with the residents and workers affected, and then the number of healthcare workers that with COVID-19 and the number treated or that were infected during treatment of other COVID-19 patients.
Jan and Chris, I'll leave that into your wheelhouse.
Okay, thanks, Governor. Chris, have you got those data in front of you? I know we are at 39 now congregate living long-term care sites with at least one case, and as you've heard us say before, we consider one case to trigger this elevated monitoring and response. So 39.
Yep, and then
associated.
Yep, and then in that situation, we have 33 resident cases and 19 healthcare worker cases. We have 173 healthcare workers who have been identified as having COVID. And then as of yesterday, I think we had 6 healthcare worker to health situations with healthcare worker to healthcare worker transmission. We had 1 situation, patient to healthcare worker, and we had 3 resident to healthcare worker. So very small proportion of those cases are linked. Most of them, I guess, the other way to say it, most of them are related to travel and other exposures at this point, community.
Thank you.
Thank you. Our next question comes from Brandon Stahl of Pier 11. Your line is open.
Hi. Regarding the alternate care site, can you talk about who would be staffing those, what the cost estimates are going to be so far, and where the funding would come from to pay for those sites?
Yeah, sure, Joe. I might turn this over to you, and this is where going through FEMA makes a difference, and Joe's expertise is there. Also dovetails with our National Guard contingent as we've started to see there of what we can use. So, Director Kelly.
Yeah, thanks, Governor, and thanks, Brandon, for the question. On the back end of the question, funding will be coming from FEMA, 75% reimbursement. We have not yet figured out exactly how to staff those centers. Some of it depends on some of the modeling that's been talked about earlier, how many and where, and are we going to be able to move staff from place to place? I do not have a cost estimate at this time.
Thank you. Operator, we have time for one more question today.
Thank you. Our final question comes from Tom Linden of Fox 9. Your line is open.
Thanks for taking the question. I'd like to go back to the question of the models and a quick follow-up on ICU bed capacity. The Institute of Health Metrics and Evaluation, this is the group affiliated with the Bill and Melinda Gates Foundation. They've come up with a model that, and I understand our state model has some give and take, 2 weeks on either side. but their model is dramatically different. Their model shows us peaking around April 19th with 49 deaths a day, a projection of 4,557 beds needed, 712 ICU beds, and a total fatality count of 1,039 deaths. The good news on this is this scenario is not as bad as the state scenario, but it's a much different timetable. Really, we're talking now about mid-April instead of potentially mid-June. So that's off by 2 months. Wondering if you've seen this model, if you believe that the difference is about the specific demographic information that we are plugging in about Minnesota.
Yeah, I'll turn this over to Jan in a minute. I am familiar with it. I've seen it. The one thing I noticed when it came up the other day and some people were sharing it is there's holes in there in terms of some of the mitigation and some of the things that we've done. But I think it does illustrate this point that this is difficult in the early stages of this. It's hard to plug in the numbers. The specific numbers are critical. The trending, again, that we're seeing on the ground, I'm still comfortable with where we're at. But as I said earlier with Esme's question is, everything we're doing was a sense of urgency to err on the front end side rather than the end. But I think the more specific ability that we have here lends me to believe that probably like so many things, it's probably somewhere in between the two. So Jan?
Not much to add, Governor, other than to say, in addition to those models that are out there nationally, more and more of them all the time, we're also talking with our local healthcare partners who are using models of their own to try to understand the similarities and the differences so that we can give you a better answer on what drives the differences. It's absolutely true. There are incredibly wide ranges out there. Some of it depends upon what ratio one uses between, for every test, what does that represent in terms of underlying illness in the community? And those ranges are very, very wide. So we'll get you a better answer on what drives the differences in some of these models. But it just, again, to the governor's point, we think our model is pretty solid, where we welcome and are seeking critique and feedback on it. But we're also trying to take some of those earlier scenarios very seriously as well, so that we're trying to prepare a good couple of weeks ahead of what our model suggests.
Yeah, that's right. And I think Jan made it. Oh, I'm sorry. Go right ahead, Tom.
No, please, you go ahead, Governor.
I was just going to say one of the things is working with our partners who are pretty good at this in the healthcare systems, of course, like Mayo and others. They are doing this too in modeling, and we're trying to bump our data off them. So it is important. We'll get more of this. I just think having some of that in the public mind, though, it can be somewhat misleading. I see people are hanging their hat on a number that got out there originally. I am most concerned what you said in the question, Tom, of the trend and the potential peak, and then bumping that off against ICU beds that are needed. I mean, even in the Gates numbers, the 800 beds certainly exceeds what we have right now at the 260 some. So it's warranted to know that either way, and when people say, did the model make you change the decisions that you've made? Not dramatically, no. We would still need to do the social distancing either in the Gates model or our model to prevent the overwhelming numbers at the hospital that we're trying to prevent anyway. So I'm sorry to interrupt you, Tom. You can finalize, take your final question.
Yeah, no, not at all. That was good information. Yeah, just to kind of nail down the ICU bed and the capacity, I guess on Sunday night, we had 255 ICU beds in the state. We believe we can augment that. And my question is, are we augmenting that? Is the plan to augment that with the medical surgical beds? Because those number about 1485 as of Sunday. So that brings us to around the ballpark of 2,000, which it sounds like we want to get to. It's about 2,000 beds. And my question is, A, is that right? And also, B, these secondary facilities that we're building around the state, these kind of stand-up facilities, am I correct in assuming that these will not be ICU beds in terms of how they're conventionally seen with ventilators, that we are still keeping those in hospitals, that these are for less critical patients? I want to make sure that we're clear on that. And does that mean, if we're looking at a total of 5,000 beds, which we said yesterday, does that mean we're trying to get 2,000 beds in the hospital and then an additional 3,000 beds in these sort of secondary facilities. I want to make sure kind of we're understanding these numbers.
Yeah, I'm going to let Director Kelly and Jan follow that up, but you're exactly right, Tom, and I think it's important to, we need the most critically ill COVID folks in a hospital, and you know, you might find the situation, and certainly I'll let the medical experts speak about it, if somebody's recovering from an appendectomy and they could be in one of these, rooms for a day or two and move on out. But Jan, I'll let you and Joe wrap this final one up.
Yeah, I think it was a great question, and I think your math is directionally right. And just to point out, when you said we had 235 ICU beds, that was 235 open ICU beds, not the total of the ICU beds in the system. So it's maximizing those we have, converting a bunch of med surge capacity, converting things like operating rooms into ICU capacity because they've got some of that ventilation equipment in them. The hospitals are thinking about this in a couple of ways, what they can stand up quickly within 24 hours of converting capacity as the wave starts to come, and what will take them several more days than that to create within the hospital campus additional critical care and med surge capacity. But a big key is moving some of the medical surgical less acutely ill into these alternate care sites. So you were quite correct about what that sort of step down philosophy is.
Governor, your final thoughts?
Well, once again, thank you all. And to the press, I really want to say thank you for your patience on this. This is not an ideal way to do a press conference. We're trying to get better at it, making sure we cater to what you need. This is my 11th day of quarantine, so maybe we can get back to a little different rhythm, but this is working. To Minnesotans, I want to thank you. Thank you for creating the social distancing, continue to work on it. And I've been ending with positive stories, and the great news is they're very easy to find. This one comes to me from the New Ulm Journal down near my home. And it was a story of Tammy Kuiper, a resident in Springfield, went out and bought 128 flower bouquets at a local flower shop and had them delivered to St. John's Lutheran Home, a large senior care facility in town. Just decency of Minnesotans, just a little bit of cheer, just trying to make sure the folks sitting over there know how much we care. So I would send my thank yous to Tammy. Thank you to the folks in Springfield and down around New Ulm. Just like all corners of the state, let's stay healthy, let's stay in this together, and let's get out the other side. Thank you all, and we'll talk tomorrow.
Well, that was today's COVID-19 briefing by state leaders. A lot of discussion today about the modeling, when peak may happen for a number of cases, and we'll make sure that we wrap all that up, put it in a very understandable way for you to digest.